Yeah. Good evening, everybody. Welcome to this month's journal club. Normally, what we usually do is to have a randomized control trial or a well-done case control study, observational studies. Generally, we tend not to do systematic reviews and meta-analysis. But one thing was the articles they had selected this time didn't seem that very interesting and useful for our clinical scenario. And second thing was this very good article came, which was a meta-analysis and probably very relevant clinically. And I think it is also probably important to understand the significance and relevance of meta-analysis and systematic review. So I thought we'll do this article. And Sanya, can you couple of minutes you can talk about what is systematic review, what is meta-analysis, because you've done talk on in the surgical society. Can you
Uh,
quickly? Yeah.
yes, sir. So in hello.
Carry on. Your audio is not very good.
Yes, sir. Even I'm getting some disturbed audio. So now you can hear me, sir.
Yeah, yeah.
Okay, sir. So basically, systematic review is where we go through. First of all we select a topic which is relevant to our for our study, or first formalize the aim which we want to compare a lot of studies together to know whether it is what the result we get. So we follow this Prisma guidelines of 2020, which has multiple checklists starting from the aim till the results, and we check each of. First of all, we select all of these studies in good databases like Cochrane reviews, Scopus, Embase, PubMed, all of them. We have to put few search topics, and as soon as we put the search topics, we'll get all the results, the studies. So whatever studies are relevant to the aim or the studies that we want to check. For example, I had planned on starting about PET scan in pancreatic cancer. So when we put up main words like PET CT, pancreatic cancer, it gives us all the studies. So those studies we take and we compare all their aims, the objectives, everything according to the Prisma guidelines and tick every checklist in the Prisma guidelines, and we statistically analyze that, and then we come to a conclusion if all these studies have given us the same opinion, or if there is any difference of opinion that is sought according to the aim.
So basically, what she's saying is you use either Boolean operators or the mesh search, and look at all the databases and look at see basically if you have if you want to come to a consensus, sometimes different randomized control trials will give you different data, different outcomes. So you if you want to collate all of that and see whether you can come to a consensus about a particular topic, as Sanya said, whether PET CT is relevant in patients with pancreatic cancer, that kind of thing. So you do that. There is also something called meta-analysis, which is a compilation of multiple studies, but the difference between systematic review, essential difference, there are many differences. Essential difference between systematic review and meta-analysis is in systematic review, you don't apply new statistics to what you have to just collate all the figures from all the systematic review, all the studies that you have done, and present it as such. But in meta-analysis, you can apply new statistics to come to a conclusion. So, for example, there was a lot of controversy about bowel preparation in large bowel cancers, and there were several randomized control studies, but many of them never reached statistical significance. So, hence, you did a meta-analysis of all these studies, and then you were able to say whether mechanical bowel preparation was actually useful or not useful. So that is one example of what meta-analysis and systematic review. So because I just thought it is good to refresh all our, especially there are two young guys who have joined, and they should know what they are actually looking at. And also it is a quick refresher for all the PGs here. Now, Ainas, you can start your journal club.
Yes, sir. Good evening, everyone. Today's journal club is on the study title "Effectiveness and Safety of Low Molecular Weight Heparin in the Management of Acute Pancreatitis." This was published. This was written by Mauro Poda et al. And it was published in the World Journal of Emergency Surgery. The study design is that of a systematic review and meta-analysis, which was published in September 10, 2024. The impact factor of the journal in which it was published was 6. The site score of the meta-analysis is 10.2, and the SJR is around 1.969. So, to begin with, acute pancreatitis is a leading gastrointestinal cause of hospital admissions and has an incidence rate from ranging from 13 to 45 cases per 100 inhabitants per year. And the etiology of acute pancreatitis is multifactorial. Uh, in terms of management, the it involves conservative management in terms of supportive care, fluid resuscitation, pain relief, and early nutritional support. However, the role of pharmacological intervention in the course of disease and modifying the disease and preventing its complications is an area of ongoing research. Uh, the disturbance in the pancreatic microcirculation is responsible for an inflammatory cascade. This is the primary factor in developing of acute pancreatitis. And Furthermore, with the release of these inflammatory cytokines, including tumor necrosis factor, that is responsible for pancreatic necrosis and damage to other organs. Furthermore, there is a role of coagulopathy also in the progression of this disease. Basically, this happens because of the extravasation of the digestive enzymes, which is causing the local epithelial cell injury. And furthermore, tissue factor exposure, platelet activation, and coagulation cascade activation. There are recent studies which are showing that low molecular weight heparin may play a role in mitigating the severity of acute pancreatitis, and thereby help in improving the microcirculatory disturbances, primarily that are mediated by TNF alpha production. LMWH will aid in decreasing TNF alpha production. There are 4 meta-analyses which have up till now evaluated the effectiveness and safety of these anticoagulants. Uh, However, these meta-analyses were limited because of the methodological issues. So, the aim of this study, the systemic review and analysis, was to amalgamate the existing evidence on the effectiveness and safety of adding low molecular weight heparin in the treatment of moderately severe and severe acute pancreatitis, and thereby providing clarity on its therapeutic value in terms of prevention of mortality, pancreatic necrosis, and complications. Going to the methodology, this study was conducted and presented in accordance with the 2020 update of PRISMA guidelines. In addition with that, it was also along the following the criteria of Moose guidelines, the Cochrane Handbook for Systemic Review, the AMSTAR 2 criteria, and the PCOS structure. Further, there were 2 reviewers who have independently conducted all the stages of the study in terms of identification, selection, quality assessment, and data extraction. As ma'am explained, the PRISMA guidelines were followed, wherein there were 27 checklist items which were assessed. Furthermore, there was the Moose guidelines which was followed. This also had a specific checklist for the background, the search strategy in terms of selection, data extraction, study characteristics, data analysis, result discussion, and conclusion. Then it also followed the Cochrane handbook, wherein these are particular guidelines for conducting a systemic review, and it is widely used for evidence-based medicine. In these, again, the key guidelines were planning a systemic review, identifying and selecting the appropriate studies, assessing risk of bias, data extraction and synthesis, and interpreting the results, and updating and maintaining the reviews. One additional criteria which was followed over here was the AMSTAR criteria, AMSTAR 2 criteria. This is a measurement tool AMSTAR basically stands for a measurement tool to assess systematic reviews. And this criteria is a 16-item checklist, as shown here, one of which includes protocol registration, inclusion criteria, study selection, bias assessment, and all of these 16 criteria were assessed. And based on this, the rating system is given based on whether it is high quality, moderate quality, or low quality. Then furthermore, this was also like in coherence with the Prospero guidelines. So the review question, inclusion criteria, strategies, and the analysis, all of these were documented in the study protocol. That was the Prospero protocol. Herein the Prospero is an internationally prospective register for systematic reviews, and here the key features of Prospero will be to like aid in prevention of duplication reviews, and this will also allow in term registering the systematic review and transparency, improving the quality and the integrity, and also like it is to register in the Prospero database, there is a it requires a high level of publication and a high impact journal. Furthermore, the PCOS structure was also followed, wherein it dealt with the patient problem, the intervention, exposure, the comparator or control, and study outcome. That is what the PCOS stands for. And herein, the patient problem, based on the PCOS structure, they developed the inclusion and exclusion criteria. In terms of the patient or the problem, the study was inclusive of a lot patients who were suffering from moderate to severe or moderately severe or severe acute pancreatitis, and patients who had chronic pancreatitis, or like studies that like studies which were focusing on pregnant women or any specific subgroup, they were excluded. In terms of intervention, the exclusion and inclusion criteria was defined as having two groups, the case group and control group, where the case group was getting LMWH and the control group was treated with the standard conventional treatment. And any studies which had LMWH, which was used for anything other than any other indication other than acute pancreatitis, these were excluded. In terms of the control group, again, like they it was to develop a standardized treatment for AP with and without addition of low LMWH. And also, this was also included in terms of study outcomes, wherein only the studies which were comparing LMWH versus the conventional treatment were included. The studies that were eligible were the randomized controlled trials of patients with moderately severe and severe acute pancreatitis, and intervention group receiving LMWH, and the control group receiving the conventional treatment. Animal studies, case reports, case series, and narrative and systemic reviews, editorials, and meta-analysis were excluded from the study. The outcomes were defined in terms of the primary outcome and the secondary outcome. The primary outcome being the mortality rate, the severity of acute pancreatitis evolution, and the secondary outcomes being the physiological assessment and recovery of functions, looking into the complications, that is SIRS, the length of hospital stay, and the adverse effects. The data extraction was done with the help of a double-blinded procedure, so as to ensure the accuracy of the data which was extracted, and it was on a produced on a Microsoft Excel sheet, and data were independently extracted by two reviewers, and any discrepancy were resolved through consultation with a third reviewer. The search covered studies which were present on the database. So, from the time of the existence of the database to February 2024, all of these studies were included. In order to eliminate risk of bias assessment, they also ensured using the ROB2 and the Robbins 1 criteria for these are two tools which are available in order to exclude the bias assessment, wherein there are 5 domains present in the ROB2 tool, and Robbins 1 tool has 7 assessments, and they they are divided into bias arising from the randomization process, bias because of the intended intervention because of any missing outcome or data, measurement of the outcome, and the selection of the reported result. And in addition to this, the Robbins one will include bias in terms of the confounding factors and bias in terms of the selection of the participants. Going to the critique.
Just a minute.
Yes, sir.
Okay. I think the juniors, two guys, just listen to it, because I think this is a difficult thing for you. Just listen and understand how a journal club is done. So basically, how journal club is done is you start as Einass has started. You talk about the methods and materials and methods, and then stop the aim, objectives, and materials and methods. Stop there, and then ask what are the good things about the study and what are the negative aspects of the study, and then we go to the next one, which is the results and statistics. Then we go to the discussion. So Nikita, you want to start off? Tell
Yes,
us
sir.
how good the study is or how bad it is.
Sir, protocol wise, it's a very good study, sir, because it's a systematic review and meta-analysis, one of the highest kind of study. And
Carry on.
second thing is, sir,
Carry on.
it's a recent study, sir, 2024 publication. And
Yes.
it's a relevant topic because acute pancreatitis and management is still a ongoing debate. So
Yes.
it's public impact factor is also not
Very
too high,
high.
but at the same time, yes, sir.
It's very high marks. 6 is good, because British Journal of Surgery is, I think, 5.7 or something. So it is very good. Impact factor is good. It's a good journal. Then.
And as per protocol, it is following all the guidelines which are required for the systematic review, sir.
Yes.
And the important factor what I have seen is this double-blinded nature of the data extraction, sir.
Okay. Good.
Which actually means that neither the reviewer doesn't know the author of the publication.
Correct.
To remove the bias.
Okay.
So that was interesting, sir. And all the statistics, what they proposed, they are going to do.
Yes, that will come to the statistics. She has not
Yes,
yet
sir.
talked about it. Okay,
Yes.
Praveen, do you want to say, add anything? Don't repeat
Yes,
whatever she has said.
yes, sir. They have used the various criteria, sir, most Prisma Cochrane guidelines,
Okay.
and they used the 3 reviewers to avoid the bias, sir.
No, that is not to avoid the bias. The 3 reviews are is to ensure congruity. For example,
sir.
if I and you are doing it, and if there is a difference in a particular article,
Opinion, yes, sir.
then we'll ask Dr. Ramakrishna to come in and go through the entire thing and say whether whether I am right or you are right, or both of us can agree on a certain point. So that is congruity. The congruity was up to 0.9%, which means
0.9.
yeah.
So they even mentioned the inter-rater reliability. Yes, sir.
Correct. Yeah, that is the so there should not be much difference of opinion about the particular one. So I think, yeah, that they have achieved that also. Vinod, do you want to add anything? Vinod, anything to add to whatever Nikita and Praveen have said?
Sir, actually, about this low molecular weight heparin dosage, sir, they said it as an average. It is about 1 mg per kg.
Don't go about dosage, because I think that comes in the end, the discussion. We have not spoken about it at all yet. Dosage,
Okay.
they have actually said that in the end. I
Okay,
think
sir.
don't go there. But anything to add apart from that?
Yes, sir. I didn't understand why they removed this hyperlipidemia from the. They have excluded the patients who have diagnosed with the hyperlipidemia.
I am also not sure why they have excluded. I don't know whether it would interfere with
In
the
hyperlipidemia, the patient would already be on heparin for other indications,
yeah.
right? So probably
Maybe
that
that
could
may
be.
be that may be the reason. Yeah, I think you're right. That may be the reason. Okay.
Sir, only for hyperlipidemia will start heparin.
They might, if they have had cardiac issues and things like that,
Okay. Okay, sir.
Yeah. Nitya and Sanya, in the end, anything to add?
So they have included both RCTs and non-RCTs.
Yeah.
So could it be considered as a pro or a con, sir? Because
No, they have excluded. See, the thing is, their criteria has been quite rigid. So only those studies which actually met the criteria, so some well conducted observational studies, cohort studies can also be included.
okay.
They may not have the same kind of, what shall we say, the statistical or the what shall we say, advisory
Methodology.
advisory value, for example, level of evidence, maybe not 1A 1B, maybe it will come to 2A 2B 2 or 3A, but still well conducted studies can still be included provided they meet the guidelines.
Okay.
Tanya?
Sir, nothing in specific, sir. Whatever I was thinking is covered.
Now, Niranjan, anything to add quickly? Hello, Niranjan? Ramakrishna, sir?
Nothing, sir. I think they have followed everything that is to be followed in a systematic review.
Yeah.
And she was using the word systemic. That's
Yeah,
what I have
systematic.
put it in
Yeah.
And
Einass, it's not systemic, it's systematic. Okay.
That's one thing. And secondly, she said it is per 100.
Not
Actually, it is
100,000.
100,000.
Yeah,
Yes.
100,000.
That's the
Yes.
one. And the inclusion, she has written only randomized. In the previous slide, she has written only randomized trials are included, but it's
There
not
are
true.
some non-randomized trials also. Yeah.
Yes, non-randomized also.
There are.
And
yes.
the other thing, the Robbins and other criteria they have used, it is is it to avoid bias or it is to assess the bias? I think
No, to try and avoid the bias as much as possible. They have actually graded the bias as very high degree of bias, moderate degree, and low degree. And they have, so
it is only assessment. That means they will be demonstrating there is a bias or not, and what is the degree of bias.
Correct.
It is not to eliminate the bias.
Not eliminate bias. Not, you are absolutely right. So, for example, if the degree of bias is low, then the quality of study is high. That's the inference we can make.
Yes.
So,
only to assess it. It's not to avoid.
Not to avoid. They
she
have
was
used
mentioning.
they have used the other criteria to eliminate a lot of studies. But after they have selected the studies, once they have collated the data, they have applied the Rob 1, Rob 2, and the Robin 1. This one bias assessment tools to see whether the evidence is of low degree bias, intermediate degree, and high degree. If it is high degree, then you have to take the results with a pinch of salt. That's probably the thing. So that is the last point all of you forgot to mention, which Dr. Ramakrishna kindly brought it out. So I think carry on.
Sir, one more thing, sir.
Yeah.
About this heparin, sir. Again, they mentioned about this will regress TNF alpha.
Yeah.
Is it a proven thing, sir? Because otherwise we can give for every ICU patient, because anyway they are in a inflammatory
Yeah,
page, that
yeah. You can. That's what I think. It's a new this one. But the thing is, you have to balance that with the risk of bleeding. So
yeah.
that is what That is why this is a new intervention, and let us see how it works out. It can be tried in other situations also, but that is what they actually tried. Activated protein C, which is also pro anti-inflammatory. It countered the TNF alpha, IL-1, IL-6 and all, IL-10 and all those things. But then it had significant bleeding problems, and many of them died because of that. So that is why it was stopped. So I think, but we'll come to that later, because it doesn't seem to affect the bleeding that much, because we are worried about that, especially severe pancreatitis, where there is variety called hemorrhagic pancreatitis. So
Yes,
if
sir.
you give them LMWH, you may cause even more problems. So that they have actually addressed that issue later. But yeah, you're right about that. It is something that can be considered, provided there is no risk of bleeding or the risk of bleeding is acceptable. Yeah,
Yes, sir.
Einass,
Yes, sir.
pretty
Sir,
good. Anything to
sir,
add, or have we covered everything?
I
Yes,
have
sir.
a doubt, sir. Sir, if you're conducting both systematic review and meta-analysis at the same time,
Ah.
what is the conclusion we are going to give, sir? Like both might or might not give the same conclusion.
No, no,
I thought
no.
both
See,
are two separate studies. Yes, sir.
yeah, no, sister, as I told you, the basic difference is you collate the data and conduct a systematic review. On to that, you can apply new statistics to actually come out with the results. So that is meta-analysis. So the
Yes,
process remains the same Prisma guidelines, everything needs to be followed. And then they have actually followed more criteria, and then uh, you apply new statistics to that, which they have done, and they have shown that it is that becomes the meta-analysis part of it.
sir. My
Basically,
question was
data
yes.
extraction will not be there in systematic review. Here in meta-analysis, data extraction also will be there. That means how many patients were there, how many developed primary outcome, what are the secondary outcome, all those things, data, that numbers, those are
Yes, sir.
extracted, compiled together, and then statistics applied again. That is
So
not there in systematic review.
we might also end up with two different conclusions then, no, sir, in
No,
case
no, no, no,
if
no,
there is,
no, no.
No.
You
because
can't.
if there are any discrepancies in the studies, in a meta-analysis, we
That
might
no, that
bring
is
it
why
out and
no, that is why they apply the bias and everything, no, so that you basically there can't be much difference between the systematic review and meta-analysis.
No, sir. What she is telling is, if some
Yeah,
studies support this is useful, some studies say it is not useful, then you have two different types of conclusions. What will you do then? That's what she is asking.
yeah.
So for that, they have calculated that I square, that is
Yeah, I square and
heterogeneity.
funnel
okay,
plot
sir.
and I square. So that
So
will
that
actually
they
tell
will say.
you. Yeah.
So if there is too much of heterogeneity, then this study conclusion is not that reliable. If
Yes, sir.
heterogeneity is very less, then you can take it that these conclusions will be useful. In
Yeah.
systematic review, they will only give this majority of the studies are supporting, so it can be accepted. If there is doubt, they will say in the conclusion further studies are required.
Okay,
See,
sir.
Nikita, when we come to statistics, we'll talk about those things, because I think it is you guys need to understand what is I square, what is the funnel plot and all those things. Okay. I think we have covered most of it. Carry on, Ma.
Yes, sir. Uh, Going to the statistical analysis, the extracted data was tabulated and summarized, and meta-analysis were conducted for outcomes where data from two or more studies were combined. The statistical heterogeneity of the results was assessed using the Higgins I2 test and the chi-square test. A p-value of the chi-square test less than 0.01 with and I2 value greater than 50% indicated substantial heterogeneity, and
It is actually heterogeneity, not genicity. There is no anything called heterogeneity.
heterogeneity. Sorry.
Yeah.
The measure of the effect for dichotomous outcomes was the relative risk, and with a 95% confidence interval. P-values of less than 0.05 were considered statistically significant, and publication bias was assessed using the funnel plots visually and using the Eggers test statistically. In the study characteristics, there were uh, 8 studies were RCT, and 5 were prospective or retrospective, non-randomized control trials. All the studies together, they analyzed around 13,709 patients who received LMWH in the intervention group, and 6,700 who received the standard treatment in control group.
No, you're wrong. 6,900 in the treatment group, 6,700 in the control
Yes, sir.
group.
Total 13,000, out of which
Total
6,000.
13,000. Yeah.
Yes,
They
yes, sir.
were
Sorry.
almost similar.
Yes.
Similar numbers. Yes.
And further limiting the analysis to RCTs, 670 patients were allocated to the intervention group and 670 were in the control group. And there were 2 studies which were conducted in India, 2 in the US, 6 studies were in China, and 1 in Turkey. Whereas there were 2 studies for which no country of origin was identified. 2 studies were conducted on the same population of patient, and the reviewers included both in pooled analysis as different outcomes were analyzed. All recorded analysis of all records analyzed the outcomes of LMWH compared with the standard treatment, and uh, uh, like uh, and with or without in patients with moderately severe and severe acute pancreatitis. 5 studies have focused on patients with severe acute pancreatitis, whereas 3 studies included patients with moderately severe and severe acute pancreatitis. Uh, Going to the test which was used to ensure to assess the level of heterogeneity across the studies, the Higgins I2 test was used. This is a statistical test in the context of meta-analysis to assess the level of heterogeneity across studies. This will help to quantify the extent of to which the results of the studies in a meta-analysis will differ from each other beyond what is to be expected by chance alone. Uh, so, uh, in While analyzing this, there are
Basically, the Higgins I-square test will tell you if, for example, if it is 0%, then the heterogeneity is almost non-existent. It is very homogeneous. Up to 50% is very homogeneous. Beyond 50%, it becomes very heterogeneous, obviously, and then nearing the 100%, it is a very heterogeneous population. So generally, what is expected is between 30 and 50%. So you need to have the I-square between 30 and 50%. Okay,
yes, sir.
carry on.
And the Eggers test was also used in order to assess the publication bias, because this bias can distort the overall findings of a meta-analysis. So Eggers test is evaluated in terms of the asymmetry of a funnel plot in order to inspect the publication bias. And Eggers test performs
Just a minute. Nikita, what do you understand by publication bias?
Hello, sir.
What do you understand by publication bias?
Sir, sometimes it could be a paid publication and their own sightings.
Correct. So basically, you conveniently hide the negative results and only publish the positive results that will, for example, if you're trying out a drug that is controlling blood pressure or something, if there are 50 patients who have responded and 40 patients who have not responded, you conveniently hide this one and just publish the figures of the patients who have actually responded. So I think, and that is one example. There are several examples. I'm sure Ramakrishna will tell us. But so basically, you try and hide the negative, results that would negatively impact your conclusion, and only publish those data which is positive in terms of your particular study. So Egger's test basically applies a linear regression analysis on the funnel plot, and basically tells you. So what actually happens in a funnel plot is you look at the scatter. So if, for example, there are studies with large numbers, they will usually be on the top, and then the studies with smaller numbers will be on the bottom. And the thing is that usually the smaller studies will probably show a lot of scatter. The studies at the top will probably show not much of this one, and it should all form a shape of a funnel. So basically that is the idea. So if it forms a shape of a funnel, then that means that the heterogeneity in the particular study is not so much. If it doesn't, if the scatter is very severe, then obviously it doesn't form the funnel, and then you can conclude that the data is very, very heterogeneous. You followed, all of you? Or
Yes, sir.
is there any
Yes,
question?
sir.
Ramakrishna sir, is there any clarification, sir?
Nothing, sir. Not of it.
Nitya,
Disturbances.
Nitya, please block people. Only who are talking can unmute themselves and talk. Sir, Ramakrishna sir, anything to add?
Nothing, sir. More or less, what you sold is okay. Thing is, it requires a lot of explanation and probably one more class to understand this funnel
correct.
plot and all. It's very complicated one. And summary, what you have said is more or less good.
Correct. Okay.
Accept.
Carry on.
Yes, sir. For the risk of bias, as explained, as initially they told in the protocol, they have used the ROB2 tool and the Robin 1 tool. When in all of the studies which were included, they have classified them into 5 domains, and based on those 5 domains, they have then graded it on the basis whether there is a very high bias or the some concern or low bias. Here we can see that like overall for a few studies they have considered like the Kuma Art study which was published in 2022, the DUJD in 2014. All of these studies are showing some high level of bias as per the ROB2 risk assessment. And they've also, in addition, also used the Robbins 1 risk assessment as well in order to assess the degree of bias as well. For in terms of the analysis of the primary outcome, the comparison of the interventional and the control group showed the superiority of LMWH in comparison to standard treatments. Herein, the relative ratio was relative risk was 0.44 with a p-value of less than 0.001 and the I2 value of around 51%. This was indicated in 11 studies, and the mortality in severe AP, again, it showed a p-value of less than 0.05, and I2 was 0%. And even in for test for subgroup differences, they showed an I2 value of 0%. And for they have also assessed, like these were the primary outcomes, so they have assessed the acute necrotic collection as well, and again showing a significant result. CT like an I2 value of 0% and a p value of 0.003, and the CTSI which was assessed, that had shown that the I2 value was 93% in this case, which was a significant. So this established a significant heterogeneity. Similarly, the similar thing was applied for organ failure, wherein the I2 value was 78% and a p value of 0.02. they have also used the funnel chart for the meta-analysis of the primary outcome. Herein, so in this meta-analysis of the primary outcomes, A is representing mortality, B is acute necrotic collections, C is CTSI, that is CT severity index, D is organ failure, and E walled off pancreatic necrosis, and F is shock. So be so in terms of the forest plot, if the diamond is entirely on one side of the vertical line, this is indicating a statistically significant effect which is favoring the intervention. And if the diamond crosses the vertical line, that is, it shows that there is no significant statistical significance.
Just a
Further,
minute, ma.
yes,
Just a
sir.
minute. You are right. See, people understand that they've said the diamond should be on the left side. That is not coming from the other. So as it is facing you, so your left hand. So if the diamond is on the left side of the vertical, that means it is statistically significant in favor of the intervention. If it is the diamond is on the right side of the vertical line, that means the intervention is not in favor of the intervention. The results are not in favor of the intervention. So here you can see most of it, but in terms of the F, you can see the diamond is across the line, which means it is not statistically significant. You followed? No, it's on the left hand side of your left hand
Yes,
as
sir.
it is facing you. Okay, right, carry on, ma.
Yes, sir. So this is how they have plotted express the data, and they have also mentioned the I2 values everywhere, including the and as well as the P values, and the subgroup differences as well. And in also in terms of the like the secondary outcomes, again, the analysis of the secondary outcomes is has shown superior outcomes, and this they have done in comparison with the Apache 2 score, wherein the four studies have shown in this, the four studies have shown an I2 value of 90%, which is showing a significant heterogeneous parameter. Also, subgroup differences are also 79.9% in this study. They have also assessed the need for ICU admission. Herein, I2 is 0% and a P value of less than 0.05%. They have assessed, in addition, the time of tolerance of diet, and this is not like there is a significant heterogeneity here, and the P value is not significant, it is more than 0.05. And the systemic complications during treatment, herein the P value is less than 0.05, and the I2 value is 0%, which is showing significance. Which is not showing a significant amount of heterogeneity. Uh, Also, they have done an analysis in terms of GI bleeding. Uh, Herein again, which has been there is low heterogeneity, and but the P value is uh, P value is also less than 0.02, the 0.05. The length of hospital stay is assessed. Herein significant heterogeneity is shown. Uh, in addition to this, they have also assessed various need for surgical intervention, vascular thrombosis, which is again showing low heterogeneity, and endoscopic intervention, wherein the I2 value was 57%. Subgroup analysis was performed according to the study design, and it has showed that in RCTs, the intervention group was superior in terms of the Apache 2 score, and they have assessed it similarly in terms of the P values and the I2 values. And they also have seen the sensitivity and subgroup analysis, and the subgroup analysis was based on the different stages of disease, whether moderately severe versus severe acute pancreatitis. And again, here there has been low heterogeneity and significant p-value seen, except for in conditions of need for an intervention. That is where there was like the I2 value was more than 50% and the p-value was like not significant. In addition, they have also used the grade quality of evidence assessment, and according to the grade criteria, the systemic review and meta-analysis of RCTs and NRCTs are compared, wherein you are comparing the interventional group and the control group, and where the grade system is usually used in a meta-analysis, and this is referring to the grading of recommendation assessment, developing an evaluation system, and this includes rating the quality of assessment, factors that can increase the quality of assessment, and strength of recommendation, which is like strength of recommendation based on the quality of evidence. That is how you decide it. And herein the grade assessment is showing like the for each outcome.
Wait, ma. Overall mortality, the assessment shows that the recommendation is of a very high degree. You give low molecular weight heparin, and it definitely makes a reduction of 55 to 65% reduction in mortality. So the level of recommendation is high. As far as the organ failure is concerned, it's a moderate degree recommendation. As far as the Apache 2, it is probably low degree recommendation. And coming to vascular thrombosis, if there is, it definitely is shown to decrease the vascular thrombosis. So for example, if you give the low molecular weight heparin early, you can avoid having splenic vein thrombosis, superior mesenteric vein thrombosis, and such like. So they definitely very useful, high degree of recommendation for reduction in mortality, for reduction in the major vascular thrombosis. In terms of the operative intervention, if you give them low molecular weight heparin, there is moderate degree of evidence to suggest that the number of operative and endoscopic interventions will become less compared to the control group. So that is what this whole study whole chart says. Have you all understood? Is there any questions, doubts about this chart? Hello? Hello?
Yes, sir.
Understood?
Yes, sir. Yes, sir.
You can see there, high degree, high level of certainty and recommendation, moderate for for the organ failure, high for venous thrombosis, and moderate for the need for surgical and radiological or endoscopic intervention.
So this is made by heterozygosity, sir. I mean, I square, high I square. They said
Yeah,
it
yeah,
is,
combination of both, combination of the I square, and also this one, the other parameter which we used.
yes, sir.
So both of them suggest that finally you come to this conclusion. Okay, carry on, ma.
Yes, sir. Coming to the discussion, low molecular weight heparin has shown significant clinical benefits in reducing mortality and complications. It is showing that the mortality is decreasing by approximately 56 to 66%, with a consistent effect in favor of the LMWH treatment arm. And further, the results of the meta-analysis are also showing the subgroup analysis, wherein most of the factors are showing low level of heterogeneity, and thereby favoring the LMWH arm. And the study supports early use of LMWH in moderate to severe and severe acute pancreatitis. However, there are certain study limitations. The one being the number of studies which were included, the risk of bias which was in the included studies, and also many there were some outcomes which had shown a significant amount of heterogeneity. like in terms of
Right.
analysis?
Now we'll come to the question that Vinod asked. So basically, Vinod, see, there is significant amount of heterogeneity in terms of the dosage and the duration of low molecular weight. Certain studies have shown that for example, what is called as prophylactic dose and therapeutic dose.
Yes,
So
sir.
those are the two doses they have addressed. So it shows that prophylactic dose is good enough, and some of the studies have shown that there is some improvement if you go to therapeutic dose. So there is a significant amount of heterogeneity there. Second thing is, there is good amount of studies which show that the dosage of up to 8 days is sufficient to prevent mortality and major venous complications, and also need for surgical intervention. So those three are definite. So there is no doubt the meta-analysis and systematic review has very conclusively shown there is significant benefits of giving low molecular weight heparin as far as those three factors are concerned, and there is also added benefit of reduction in the number of hospital days stay. And in terms of organ failure and use of Apache 2 scoring and all those things, there is the evidence is not that good. However, if you continue beyond 8 days, in up to 14 days, even after discharge, if you continue to give them LMWH, there is an added benefit which they have not been able to show because of the heterogeneity. So what they have recommended is that we need larger randomized control trials looking at the dose which is either prophylactic or therapeutic, and also looking at you have to maybe make 4 groups. One is a prophylactic group for 8 days, second one is prophylactic group for 14 to 18 days, third one is therapeutic group for 8 days, and fourth one therapeutic group for up to 14 to 18 days. So if you do a large randomized control trial, maybe some of these questions may be answered. But there is no doubt about the efficacy of low molecular weight heparin, whether it is therapeutic dose or prophylactic dose, in the three major areas of concern: mortality, major venous thrombosis, and need for operative stroke, radiologic stroke, endoscopic intervention. Are you all clear about what this study shows?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, a critique now. Nitya, what are the things that you think is good, and what are the things it may be, you may have problems with?
Sir, the heterogeneity that we just discussed, that is one thing that is something that, like how you said, we need to form separate groups and then do an RCT. That is one thing, sir. And then the probability of a publication bias that in the studies that have been included, that needs to be
No, but
considered.
there is no not much of publication bias, because if you look at the forest funnel plot,
Yes,
the
sir.
funnel plot is also called the forest plot, and the forest plot is, if you see, the diamond is most of the time on the left of the vertical line.
Yes,
So
sir.
there is not much of bias, and they have quantified the bias. So wherever the
Hmm.
bias, see, the thing is, they have been very clear. Wherever the bias level is high, the level of recommendation automatically becomes low. So
Yes.
it is very, I think it is, they have done a very, very good job on this one, because every possible thing has been addressed, and wherever they have not been able to address, they have actually admitted that, because the level of heterogeneity is so much, we can't draw conclusions from this, that is, for example, the difference between the prophylactic and therapeutic dose, the duration of the dose, and certain other areas. They've said we have to do better studies to get answers for that question.
Yes,
Tanya,
sir.
any other point you want to add?
No, sir. They have actually used it very perfectly and nicely to tell which is more important, and which has more like we showed high, moderate, and low heterogeneity that it had, which is
Yeah.
like mortality and vascular thrombus. All that they have focused on, like very well evaluated and came to those conclusions, sir.
Niranjan, anything to add?
Nothing, sir. Nothing.
Ramakrishna, sir?
No, nothing, sir. Everything is discussed. Only thing is, even with systematic review and meta-analysis, sometimes we may not be able to give firm conclusion. Like for some of the criteria, this low molecular weight heparin is good. For some of the criteria, it may not be useful, like reducing the hospital stay and all that
Yeah.
they have shown. So for
Yeah.
those things, we need research, further research with a specific research questions.
Question, yes. See, what you have to understand is, because these are, when you look at the data and this one, the scatter plot or the all these things, basically some of those questions probably would not have arisen when the study was being conducted. But then when you go back, you think, shall we answer these questions? So those questions may not be addressed. So that will be the sort of drawback of meta-analysis and systematic review. So I think basically, as we keep, Dr. Ramakrishna, Dr. Lakshman, myself, we keep telling, protocol is the most important, bedrock, or the data of the data. So the protocol should include everything, where you should address all factors, bias, confounding factors, and in fact, even you have to mention what equipment, what manufacturer that you have used for a particular equipment. Everything has to be mentioned in the protocol. And this RCT, the consort diagram should be there, where all the factors, where patients who have dropped out, who have, whether you have included them in your intention to treat analysis, all these things. So basically, the data collection in an RCT and the following of the consort diagram becomes critical. So they have actually looked at all of these things, and certain areas they have found significant heterogeneity, which means some results are in favor of the thing and some results are against. So there they have actually said the level of evidence is low. So that they have done. Einass, anything to add in your critique? Shows whatever you have written.
Yes,
Sir, I have a point, sir, in critique.
Yeah.
They actually added 2 abstracts, sir. Like in the
Ah.
13 studies, 2 of them were
Ah.
just only abstracts without full text and full details. So is
Yeah.
it acceptable for only the abstracts to be a part of the meta-analysis, sir?
No, that is why there will be some inconsistencies, obviously.
Okay. And in the like description of the results also, in one point they had mentioned a wrong number, sir. Like need for ICU stay, 11,000 patients they had mentioned in 2 studies. But overall the study population is itself is the 13,000.
No, I didn't see
There
that.
was a little small discrepancies are there in the data points, sir.
I think we have covered most of whatever is written here.
yes, sir. Only that subgroup analysis, like not
See,
all.
other thing about subgroup analysis, and Dr. Ramakrishna will also, probably talk about this. See, basically, see again, this is the importance of protocol. So what you have to do is, in your protocol, you have to, you have to very clearly specify that are you going to do subgroup analysis, and are you going to use multivariate analysis, regression analysis. All these things have to be very clearly stated. Otherwise, what happens is, let us say you wanted to show that there is significant difference between the intervention arm and the control arm, and it doesn't show it. So what you then do is what we call as the post hoc analysis. That means after you have done your study, you add, we will look at diabetic group. Just to give you an example, you are looking at a control group and the intervention group, there is no difference. Then you say, oh, we'll look at the diabetic group, and in diabetic group there is difference. So this particular intervention is useful in diabetes. That may be true, but the problem is the fact that it was done as an afterthought, as what we call as a post hoc analysis, means that there is a significant room for bias, because you are not being able to show. See, it is not wrong to say that the treatment actually did not make any difference for this particular condition. But some people think that they always have to show that the treatment has been effective compared to the control group. So they will, do all this post hoc analysis, and we in proper, academic circles, post hoc analysis is frowned upon. It is not considered to be a good practice. If you want to do subgroup analysis, you should include that in the protocol, and you should say we will look at it as a generic group. We will also do analysis between diabetics and patients who are above 70 years, whatever. You can do whatever you want, but if you state it in the protocol and all those things are very well documented, then it is fine. But if you do it as an afterthought, then it means that there is bias, that you have somehow managed to massage the figures or whatever. Ramkrishna sir.
It was a good discussion, and probably for the first time we are doing this meta-analysis and systematic review in Journal
Yes, sir.
Club. So we need some more experience to make it more perfect. Probably in due course we'll get more experience.
Yeah. No, but that is why when Einass was doing it, because this is first time she is doing it, I took over at certain parts just because I think she was struggling. I think it is understandable because she's just first year now. I think I didn't know any of these things when I was first year, so she's done a very good job.
Yes,
Now
yes.
let us come to conclusion, ma.
So the discussion and the conclusion were the same, sir. Like that is
Okay.
what they
Right.
told,
Yeah.
sir.
So now, so what's the time?
10
10 o'clock.
10 o'clock.
Yeah,
Yes.
we finished on time. So Sanya, Nitya, comments. I think either Praveen or Nikita comments about the paper, about Einass's presentation.
So, the
Quick.
paper itself is interesting, sir. The whole meta-analysis and the new analysis we came across from this journal, and she rightly described about all the new guidelines as well as the statistics involved, sir.
Correct.
It was over a good presentation with a nice PPT, sir.
Nitya or Sanya?
Sir, Einass did a very good job, sir. Honestly, even as a postgraduate, I have not done a systematic review and meta-analysis for a journal club. So she did a very good job, sir.
Okay. Niranjan, your thoughts?
Sir, it was good learning, sir, and she did well.
Ramakrishna sir, what are the areas you would suggest that we all improve?
Ade, we need to discuss separately about these things at that funnel, then this bias, how to assess the bias. Those things they have given, that Robbins criteria and all.
Yeah.
Those things we should discuss separately, so that we can apply it next time in Journal Club of Systematic Review and Meta-Analysis. Those things we should know, especially this Prisma guidelines, all those things. We need a class on that. After that, we will be able to do it in a better way. Here,
So
one thing is there
Yeah.
is overall decrease in mortality, but when it comes to the specific complications like organ failure and vascular thrombosis, there is not much of difference.
No, vascular thrombosis there is, but organ failure there is not.
Vascular thrombosis, yes.
Yeah,
Organ
there is.
failure and complications.
Hospital stay, ICU stay, there is no difference.
Without making difference in those things, how this mortality got reduced, it is something surprising. Because the complication and organ failure, when that rate decreases,
I think the
we expect mortality also decreases.
only explanation I can say is that maybe there are more intermediate, moderate degree of pancreatitis compared to the more what we call as high degree. As far as the acute pancreatitis, the low, moderate, and severe. So maybe the severe patients are comparatively less compared to the intermediate degree. Maybe that is the reason.
Because this study is concentrating on non-mild, that means moderate and severe. Those two are
those two
concentrated.
groups, if there are more severe patients, you would have expected as you said, if there is no reduction in ICU stay, no reduction in the organ failure, it will consequently, affect the mortality as well. But if there is more number of moderate degree or intermediate degree patients, they may not necessarily have, organ failure and so on, or even the organ failure is there, it may be less severe and recovers faster. Maybe that may be the reason. Difficult to say. Overall, I think, Einass, you did an excellent job. I'm sorry I had to take over in certain areas. That is because I just wanted to move the presentation along, and I understood that it is difficult for you to actually, because it is a complex thing. I think even I don't know much about this anyway, but that is why I took over. But you did a very good job, and I would say that it is certainly very interesting that we should start using low molecular weight heparin in patients who have acute pancreatitis. I think certainly it is definitely, because the complications, they have very clearly shown that bleeding complications are not any different compared to the control group. I think we can safely start low molecular weight heparin, maybe in a prophylactic dose initially, and see how it affects the outcomes of the patient. I think certainly I would change my practice based on this meta-analysis. So I think that much is sure. I think that is probably the gist of the study. I think thank you very much for all of you for a very healthy and very good discussion, and good night.
Good night.
Good night.